My background is based in the Caribbean, which is where I grew up, and I did all of my primary and secondary school in Barbados, which is where my family still live. And ever since I can remember, ever since I was a little kid, I remember being interested, being fascinated by medicine, and surgery in particular, actually. So whenever anyone in our home was sick, we had these 4 medical encyclopedias, and I'd run to them and try and whip them out and try and find the diagnosis of what was wrong with my mother or my father, my sister, or whoever. So my interest in medicine and surgery in particular goes back for as long as I can remember. It's always going to be about being a doctor and a surgeon in particular. And I was, very lucky during the course of my education. That didn't change. I had a great education back home in the Caribbean, in Barbados. And at the time when I was looking at honing in on what I wanted to study at university, post A-levels, I was going through a lot of dental treatment myself. So I had an interest, if you like, a personal interest in dentistry. So I thought I would go to university and study dentistry first and foremost. And I got a scholarship from my government in Barbados to come to the UK to study dentistry, which is what I did. And I studied dentistry in Scotland first of all. So I came here at the age of 18. And then after I qualified from dental school, I felt that I wanted to spend at least 6 months in a hospital environment in the UK before I returned to the Barbados, to the Caribbean, because I felt that undergraduate oral surgery of the mouth, wasn't very well taught. And I wanted to do a 6-month job in oral surgery in the UK before returning to Barbados. And I did my first job at St Thomas's Hospital in London with a then consultant who was probably one of the foremost maxillofacial consultants of his generation. He was very well known. His name is Derek Henderson. And he gave me my first job ever straight from dental school. And he was an amazing man. He was a short man, fierce in temper. He was a real hard taskmaster. And despite the fact he was a difficult man to work for, he was extremely good at what he did. He really was an amazing surgeon. And he liked me, we got along very well. And because of his prominence in the oral and maxillofacial surgery world, and what I was exposed to there as a very junior trainee, that ignited my interest and my passion for oral and maxillofacial surgery, for surgery of the head, neck and mouth region. And that's when it really all started. The correct title for the specialty that I do is called Oral and Maxillofacial Surgery. So the oral refers to the mouth, maxillo refers to the jaws actually, that's a prefix that refers to the jaws, and facial obviously the face. So the surgery that we do, and that I do, is surgery of the mouth, jaws and face. So really anything from the neck up. There are similarities between the kind of work that we do as oral and maxillofacial surgeons and the work that ENT surgeons do and the work that plastic surgeons do. There's an awful lot of overlap. The difference is that we in oral and maxillofacial surgery have to have a double degree. We have to study medicine and dentistry. It's compulsory. So the kind of work that we do can revolve around congenital problems, people who are born with facial deformity. You can carry out surgical procedures where you are doing what we call osteotomies. So you're breaking their jaw bones electively by making cuts in the jawbone and repositioning them, moving them backward, forward, up, down, whatever, to try and improve on the patient's facial appearance and also their bite, the way their teeth meet. So if you see patients, for example, who have a typical, almost like bulldog-like appearance, where the lower jaw is further forward relative to their upper jaw, you can break the jaws and move them in the other direction, take the lower jaw back and bring the upper jaw forward. So that improves their appearance and their bite significantly. Equally, patients who have a goofy-like appearance, where the lower jaw is back here and the upper jaw is up here, you can break their jaw and bring the lower jaw forward so that it improves on their bite and again their facial appearance. So that's one thing that we do. Maxillofacial trauma, or patients who are victims of assault, interpersonal conflict, violence, fights, that sort of thing. Lots of any sort of facial fractures, that we treat all those. With the background in medicine and dentistry, it's very important not just to fix the bones back to where they were, but also to make sure you get the bite correct, make sure everything's perfectly aligned. We also do things like salivary gland surgery. We do things like what we call craniofacial surgery. So patients who have facial syndromes can be treated also by people in my profession as well with a subspecialty area of interest. We do a lot of facial aesthetic surgery now. We do a lot of skin dermatology, surgical dermatology. I have a particular interest in TMJ surgery. TMJ is a temporomandibular joint. That's the fancy medical term for the jaw joint. And my reputation is being built around my TMJ practice. I'm very well known for that internationally, and jaw joint reconstruction in particular. So in the same way that people can have artificial hips and knee joints, we can these days also give them artificial jaw joints. And they can be either stock implants or they can be special custom-made implants which are made based on virtual surgery, web-based technologies. It's very niche, high-end stuff really. So that's a small part of what we do as oral and maxillofacial surgeons, in fact. There's a lot more to it than that. There's rhinoplasty surgery, nose jobs, cancer operations. Head and neck cancer is a big deal, of course. And maxillofacial surgeons like myself also do all the head and neck cancer. Not just the resection of the tumours, but also the reconstruction of the tumours using techniques like microvascular surgery, where you're taking grafts from other parts of the body and you are plumbing it into the defect in the head and neck region and anastomosing the veins and arteries that go with it as well. My first memories as a dental student were very positive actually. I loved it. I had a great time at university, and I came straight from Barbados at the age of 18 to go to university in Scotland, which is a big sea change. You can imagine, the weather was different. I'd never seen snow. Winter was a nightmare. Scotland was the lifestyle is very different from the lifestyle back home in the Caribbean. But having said that, I had a great 4.5 years in that sort of academic environment with very good friends from other parts of the world. So it was a fantastic 4.5 years. They often say that university years are the best years of your life, and that for me was certainly, that first experience was absolutely the case. It was amazing. Medicine was slightly different because as a medical student I had already done my dental degree. I had already worked for 3.5 years, so when I started medicine I was already a mature student. Well, I was older, I was 25, 26 when I started my medical degree, and my responsibilities then were very different. I had to help fund my way through my second university degree, the medical degree, so I had to do some work on a regular basis while I was a medical student. So all the partying and the socializing wasn't on the same level as it had been when I'd done my dentistry when I was 7 years younger. But having said that, I equally enjoyed it. I think when you recognize that this is something you have to do because it's about pursuing your ambition and pursuing your desire, that you realize you have another 5-6 years of hard work and graft and exams, especially through medical school, which is never easy. But that is your focus. Your focus is just succeeding. It wasn't really a problem. I mean, it was hard work, true, but you know what they say, most things in life that don't come too easily, actually, most things in life that are worth it don't come too easily, and you have to work for it, and I have no problem at all with that, and it does pay off, is all I would say. I think hard work and initiative and drive and really ambition for what you want to succeed to do in life is very important, and it does pay off ultimately, in my view. When I first started working here at King's, I've been a consultant for over 10 years now. The first 2.5 years was spent as a consultant at Charing Cross Hospital in West London, and then I moved to King's in 2006. When I first came to King's, it soon became apparent that jaw joint problems are exceptionally common. I mean, very common. About 25% of the population will at some point in time in their lives have problems with their jaw joints. So 1 in 4 people, that's a lot of people. So it's one of the most common problems that we see presenting to maxillofacial departments, dental institutes and so on. So it soon became apparent to me when I moved here that it was something that wasn't very well managed at all. It was managed by several different specialists, and they all managed it differently, and no one really had any kind of a handle on a cohesive treatment algorithm for the way it should be treated and managed, especially from the surgical perspective, and I'm a surgeon. And that's what really got me involved in it, especially the jaw joint reconstruction side of things, because there are only a handful of surgeons in the UK, in Europe and in the world who do jaw joint reconstruction, so it's a very niche area. And I started to explore possibilities of being taught how to do it, to do jaw joint reconstruction. And it soon became apparent that I'd opened a can of worms, because that's how things developed very quickly. That's when all the referrals started to come in as I went abroad and learned how to do it, how I trained how to do it. And it's been amazing, I have to say, for me personally, that it's really allowed me to develop myself professionally and personally and help people here and abroad in a big way. Okay, so you asked me about a very interesting case I did on a patient called Sandra Pierce, and the medical surgical procedure and what that entailed. Sandra was by far the most difficult and challenging case as a surgeon I've ever done. It took me a year to plan the surgery. The significance of her deformity was such that it was extremely high risk. So we had a number of discussions with her and her family about the risk of taking this on, because there's a chance that she might not be able to live through the procedure. And we also had many discussions with other members of various teams, neurosurgeons, community special care dentists, lymphedema, vascular surgeons, manual handling teams, all sorts of people actually, anaesthetists, because it involved a true multidisciplinary approach to be able to get her to surgery and physically do the operation on her. So having sourced all those opinions from different specialists about the best way forward, it was felt that the best way forward would be for me to proceed to do this jaw joint surgery for her, to give her artificial jaw joints, to release what we call an ankylosis, which is fusion of her jaw joints. So her jaw joints had fused to the base of the skull, and so it meant she wasn't able to open her mouth for 20 odd years because of this condition that she had called juvenile idiopathic arthritis. And one of the possible complications of that is ankylosis. So all of her joints had fused, not just her jaw joint, her wrists, her ankles, her neck was fused in a position like this, such that her chin point was almost touching her chest, and it was rigid, it was like bamboo, you couldn't move it at all. So the anaesthetic risks for her were huge. So it took a long time to plan the surgery. So a year later, and the surgical planning which I did, which was all done virtually, using the computer web-based technology we now have at our disposal, and a company in the US that I work closely with called Medical Modeling. Their biomedical engineers design the implants based on CT scans I have taken of the patient, and they're converted into three-dimensional images of the patient's face and jaws. So they design the implants virtually with my help through a web-based technology and through a conference call, which we do on a few occasions to get the design just right. Once the design is made, the implants are then manufactured by a company called Biomet. We're also based in the US, they're based in Florida. And then the implants are produced and then I put them in. So that's a rather simplistic way of putting it, but on the day of the surgery, it took us, as I said, a year to plan. It took us 4 hours alone just to get her positioned on the operating table and get her off to sleep, because the anaesthetic was so high risk, and the first attempt had to be abandoned. But positioning someone like her on an operating table when she can't lie flat because her back is so curved, very difficult. So we got several special aids in on the day to fit her on the operating table so she wouldn't slide off. So vacuum molded bean bags to make sure that she was secure on the operating table. I had a team of about 20 in theatre helping me on the day. We got the manufacturers of the operating table in so they could disassemble and reassemble the operating table around her so that she was in exactly the position I wanted. And we got the manual handling team to use their hoist to lift her onto the table and so on. So it was a very intriguing day. So 4 hours of positioning to get her off to sleep. The operation itself took me about 6 hours to do. A back-breaking surgery, but it went very smoothly, I'm pleased to say. It took us about another hour and a half to get all of her teeth out, which is part of the problem, to do what we call a dental clearance and extract all of her remaining teeth, which were in a very poor state anyway. And then another hour to wake her up. So the operation in total took about 13 and a half hours to do, a labour of love. And she did very, very well. You know, we got her back to the theatre about 3 days later and tried to extubate her, but were unsuccessful in doing so because of the amount of swelling around the breathing tracheostomy tube. And then we brought her back 1 day later after high-dose steroids and managed to extubate her amidst very emotional scenes, I have to say. Because we knew we had a timeline to get the tube out. The longer you leave a tube in a patient such as her, the more dependent they become on the ventilator, and the more difficult it is to get them off the ventilator. And then you have a real problem. Then you are in a catch-22 situation where there's nothing more you can do. But thankfully we managed to get her extubated on the 4th day, and after that she did extremely well. And her story was so interesting and so extreme that it was picked up by the national press, and so it was in the Daily Telegraph, the South London Press, the Evening Standard, and it was a big deal actually, yeah. So she did very, very well. The sad thing, however, I have to say, and you know, over the years, I mean, I've known Sandra for about 4 years, and she was a patient, but because we had such close contact, and you know, we went through a lot together to get her to that point, she became a friend. And about 6 weeks ago, sadly, Sandra died. She died of a pulmonary embolus, so she had a blood clot in her lungs. She was a sitting duck for that sort of thing to happen because of the whole range of medical comorbidity problems that she had. And she died in the arms of her now 17-year-old daughter, who was 14 at the time when I did the surgery. And I was at her funeral a few weeks ago. It was a very difficult personal experience for me. But you know, I will always be comforted by the fact that Sandra always said to me that, you know, if she had to go through the whole process again, knowing the risk and knowing what she had to endure, she would do it exactly the same way. Because, you know, I gave her the opportunity for the last 3 years to be able to, you know, eat her way through most of the restaurants in Southeast London and to live a normal life like you and I, to be able to eat, open her mouth, stick her tongue out at her children, that kind of thing. Those kind of things that you and I take for granted. She was able to do for 3 years before she sadly died 6 weeks ago. The kind of surgery that we do is extremely rewarding because, you know, it's the facial region, it's the head and neck region, it's a very visible part of the human body. It's a part that we all, when we see people initially, that's what we see, and that's what we, rightly or wrongly, that's what we judge people by. We actually form an opinion quite quickly on people based on the way they look, and that's perhaps not the way it should be. That is a fact of life, actually. You see someone walking down the road, you decide if that's someone who you think you like or someone you don't like because of the way they look or they carry themselves. So the face is extremely important, and for that reason this kind of surgery is so worthwhile. And what makes it worthwhile is when you have patients turning to you and saying, you know, Mr. Matthews, you really changed my life. That makes it all worthwhile for me, actually. I go to the gym. I like going to the gym. That's my de-stressing mechanism, I have to say. I love traveling a lot. My family are very important to me, so I love traveling, especially back home to the Caribbean. That moves you out of this busy, crazy mindset in London, doesn't it? The Caribbean is a lovely, laid-back, languid attitude to life. You're chilling out on the beach, that kind of thing, in the sunshine, what have you. That's my de-stressor. And I think it also helps being very organised. And I'm naturally a very organised person. I have things that have got to be very organised to me in a structured way so that you know what your deadlines are, you know how much time you have to meet them. So you give yourself sufficient time to meet them appropriately, prioritising what they are and hitting them appropriately, not leaving everything until the last minute, because that's what makes you stressful, actually. And you know, the life of a surgeon isn't just about the operating, especially as a consultant. That's a tiny part of it. It's all the other stuff. It's the teaching of your trainees. It's the clinics, it's dealing with patients. It's private practice. It's you know, I have lots of other roles educationally, both nationally and internationally. I've got, you know, surgical consultancy with companies like Biomet that I'm also involved in. So there's a lot of strings to one's bow. And the more successful you become, the more people ask you to do things, to lecture and so on, which is great, which I love. But so you've got to be organised in a way to be able to do it. So taking time out away from that, de-stressing in the ways I've just described, are extremely important.